Good afternoon, and you're all very welcome to this afternoon's QPS TalkTime, coming live from the Department of Health, where we've just had a very fruitful morning with colleagues from the Department of Health and ISQua. And our theme today, following that international collaborative workshop, is running health delivery systems in an era of great challenge, keeping the orchestra playing while rewriting the symphony. The purpose of today's session is to explore QPS opportunities and challenges during health service reform, how to keep systems under pressure safe, and sustainability and future safety and quality of our systems. And a reminder, as ever, that you can follow us on YouTube and on LinkedIn, and the links are on the screen. I'd also remind you that these talk times are now available on Spotify, and I would also draw your attention to the QPS Competency Navigator that was launched in the last month, and also our National QPS Prospectus of QPS education and learning programs that are available, and you can scan the QR code on screen right now for that. So we're about to start our session now, and as I said, we're exploring the current and future pressures on the healthcare system from local to a global context, and how we can adapt to those pressures. We have both national and international guests on the special QPS talk time, and as I said already, we'll be talking about opportunities and challenges during reform, how we stay safe while under pressure, and how we create sustainable systems for future quality and safety. We are very fortunate to be joined by esteemed colleagues from across the globe. Dr. Karen Luxford here to my right, who is an ISQua board member, but also Group CEO of the Australian Council on Healthcare Standards and HSE International. All our guest bios are available online, so I'm not going to go into them in detail. To my left is Dr. Joan van Vliet, who is ISQua President-elect from the Netherlands. I'm also joined by my colleague and counterpart in the Department of Health, Rachel Kenna, who's Chief Nursing Officer for Ireland, and patient safety falls under Rachel's remit. And of course, my equal in the department, Ms. Kate O'Flaherty, who's the Director of the National Patient Safety Office in the Department of Health. I'm hosting the session, and my name is Orla Healy, and I head up the Quality and Patient Safety function in the HSE. So Kate is going to speak first. And Kate, in your role as Director of the NPSO, could you tell us a little today about why it is important for the patient safety community in Ireland to engage with international expertise?
Thanks, Orla. I suppose the answer to that is really kind of twofold. So one is on I suppose a practical opportunity level. We work very closely with ISQua and with other international partners such as the WHO and the OECD. So we take every opportunity, particularly when people are in Dublin or in Ireland, to kind of get together and provide a platform and a forum for all of our stakeholders, from patient advocacy groups, regulators, people working in QPS, to come and talk about the themes. And of course, Ireland is looking forward to hosting the International ISQua Conference in 2026. So everything we're doing now is a lead into that. And those connections are really important for many reasons of, across the globe, we're all facing the same challenges and the same pressures. And I think when we hear later from Karen around, the sustainability and climate crisis, it makes the globe a very small place. So we can't really sort of say, in Ireland we're doing this, or in Australia they're doing that. We need to come together as a global community. I think it's really important. In Ireland, we're always comparing and benchmarking ourselves internationally, and that's a very important part of patient safety policy direction, as well as kind of measuring our quality improvement, measuring, I suppose, analysing where our gaps are as well. But also, I think when we come to international fora, to hear about some of the good things that we are doing in Ireland and the opportunities and the assets that we have that we leverage very well. And so it's a real sharing of opportunities and experiences and stories from international partners. So I think it's really important for us, particularly, as you say, when people are under pressure, the system's under pressure, healthcare workers are busier than ever. There's a lot of information overload, as we heard today. Linking in internationally and to international thinking and to international idea exchange really is good for your headspace as well, to be able to maybe put a new framework around how good we are doing, why we are focusing on the things that we are, and as I say, learning from each other, because we want to be in a learning system. So for me, I think the globe is a very small place. And it's lovely to have an opportunity to meet in person with some of our international experts and peers for us to exchange learning and see how we can help each other meet the challenges that we all face together.
Thank you very much, Kate, for that excellent synopsis. Our next speaker is Karen Ellen. Who is, sorry, Ellen Joan, sorry, Karen's to my right, Ellen Joan, President-elect of ISQua. We've had the pleasure and the privilege of hearing your presentation this morning. So I know, I can assure you that you're in line for a highly entertaining, informative presentation from Ellen now, who's going to talk about systems under pressure, how to guarantee safety, intelligent risk taking, and discuss the impact of hierarchy on the healthcare team. So over to yourself, Ellen Joan, and thank you so much.
Thank you, Orla. So this morning I had the opportunity to talk to you about the importance of intelligent risk taking if you are working in a system under pressure. And I also like to talk about why and how. So why is it so important that we make sure that we are prepared to be safe and to keep up with the pace in disruptive times? And that's the sheet that's now on. Change is going faster and faster and faster. And I like to illustrate that with this picture. What does disruptive change mean? Because it means we have to be able to keep up with the pace and absorb these changes. And you see at the first line, the telephone. And it took the telephone, when it was introduced, 75 years to come to 50 million users. If we go down, then you see Facebook. You have 3 years, up to 50 million users. And then you see Pokemon Go. In 2016, so nearly 10 years ago, it was released and it took 10 days to go up to 50 million users. So that is disruptive change. And, well, then we have some bad news. Because we are not very good in dealing with uncertainty and risks. Our brains are not well equipped to evaluate uncertainty. It makes us less capable, more irrational in our decision making, in our reacting. So we experience a decrease in motivation, in focus, in even how we collaborate with each other, how we behave, our self-control, and our overall well-being deteriorates. And for the ones who want to practice their Dutch skills, I have a nice graph here. And you see a weekly pattern, Monday, Tuesday, Wednesday, Thursday, Friday. And it shows our risk tolerance, or to say our appetite for risk. And we think that we are very rational, but in fact we are not. We even have a weekly pattern. So that's what I said this morning, like if you have on your agenda tough decisions to make and you want them to be conservative, do it on Thursday. If you want it to be progressive, do it on Friday. So I think the photograph shows how irrational we are actually in our risk-taking behavior in practice. And then go back to healthcare teams. healthcare teams are in particular at risk for poor risk behavior. And why is that? We tend to have harmonious family cultures. And we also work in hierarchies with professional autonomy that we have to deal with. And we are facing with disruptive knowledge drains at the moment. So how do we practice intelligent risk-taking? And it's increasingly important to ask ourselves the questions when and why and how much risks are we willing to take? So, and now we go to my final slide. I shared this example this morning as well. In America, 2016 again, we had this research published group, a journalist group. They dug into the Medicare database and they published the rankings of clinical outcomes. So who's the best and well, who's at the bottom of the list? So one is first and one is last. And what happened when they put out these publications? Obviously, they interviewed the best performing orthopedic surgeon it was. They interviewed him and they asked him like, well, what's your secret? And he responded like, it's all about being how responsive you are and how responsible you are in working with your team. So they invested in teamwork. And he said, well, actually, it's really a team effort. And then, well, suppose that you would be at the bottom of the list, like the top, the last 25 of the list. How would that make you feel? It will make you feel very vulnerable, but it will also be the strongest incentive to improve. And I think that's a message for our system. If we want to make the curve move to the right, we have to make sure that we have to keep them accountable. Don't blame them because they will hide. Make them accountable, follow up, and create safe learning spaces in which they can improve. So I think that's what I wanted to highlight about the importance when we are in times under pressure with these rapid changes. We have to practice how we take risks. So thank you, Orla.
Thank you very much, Ellen, Joan. So intelligent risk taking, it sounds contradictory from a risk management approach. We learn to mitigate risks, and you talk about risk appetite. And can you explain why you do this?
Yeah, I like to change the mind. I like to open the perspectives and open the minds because the risks are knocking at the door. They are there. And this morning, he put it very elegantly, incidents don't wait to happen. So they will happen. And when we are in these disruptive changes, these times, we know that there will be new risks that we even cannot anticipate for. So how do we prepare each other? How do we prepare ourselves? The only way we can do that is by discussing it, by really making the trade-off explicit, rather than just let it happen. So I think that is the most important thing is get it out on the table, create a learning culture, create awareness and build preparedness and foster the debate. So this is where I also like to get into the example, if Disney ran your hospital. If Disney ran your hospital, the book is quite old already, but one thing really struck me, and that was you have your objectives, you have your values, and we say quality and safety is a multidimensional construct. So that means there are multidimensionals in it. So what's the hierarchy? How do you prioritize them? And that's why you have to talk about what risk are we willing to take? Because if you don't, you take it anyway. So make it a conscious action. That's why I want to change the stage, the focus.
Plenty of food for thought there. Thank you very much. So next up is Dr. Karen Luxford, who's joining us all the way from Australia. And Karen, over to you. You're going to speak to us about environmental sustainability based on your personal and professional experience.
Thank you. Thanks very much, Orla, and thanks for the invitation to be here. And as Kate mentioned, it's a real opportunity for us to share and learn internationally. We've been focused on environmental sustainability, particularly in relation to impact on health, but also what healthcare services can do. And I think that this is a challenge that unites us all across the globe. We've certainly seen the warnings from the UN around a global climate crisis that is occurring. And certainly, even in Ireland, I know you've experienced that impact. And particularly in Australia, we've seen the impact over many years. Bushfires, floods. We currently have a cyclone which is heading for our coast. So we're seeing that impact across the whole community, across healthcare services. And we're particularly focused on some of that message that's been coming out from the World Health Organization. So particularly in relation to global health, WHO has said this is the biggest health crisis that we are facing as humanity. It's the most important thing for us to be addressing. And I know many challenges occupy our focus, but this is one for ensuring that we do have a planet to continue to live on. And so when we look at the evidence around where we're at with global climate change, we know that if we considered healthcare as a country, we would be the 5th biggest emitter of carbon emissions. We account for 8% of global emissions as healthcare services. So that's an enormous challenge facing us. We equally know that if we don't check this deterioration in climate emissions, that the sorts of things that we're going to see as increased malnutrition, increased disease, increased issues with heat stress are going to in turn impact on the healthcare services. So in a sense, it's catch-22. We are contributing as healthcare services, but we're also going to experience that impact. And so in response to this, many governments, and I know Ireland is doing great work in this as well, are responding by producing new standards around sustainability for healthcare services, and are really looking to how do we encourage healthcare services to be decreasing those emissions. So as an accrediting agency, this has been one of the key ways that we can contribute by working with the healthcare services that we accredit to encourage change. So from a global level, we're seeing many healthcare services join networks such as the Global Green and Healthier Hospitals Network, which provide resources for health services that are wanting to understand how can they make a difference in this space. We have governments in Australia. Our Australian Commission on Safety and Quality has released a paper which is, again, very practical. What can you do as a healthcare service to promote environmental sustainability? And so working with those healthcare services, we've seen some fantastic initiatives to support decreasing carbon emissions. One of the examples from Sydney, which is where I'm located, is a hospital that we accredit that wanted to look at how could it reduce emissions from anaesthetic gases. And they're a big contributor from healthcare services. They looked at the literature. The clinicians worked together with hospital management and administration, and they worked out that if they stopped using desflurane and they converted to another gas, they would have equal quality in terms of their patient care, but that they would decrease their carbon emissions by 90% in that area for gases. And they saved tens of thousands of dollars for the hospital each year. So there are some really practical things that health services can do, and we are really working with those health services to bring those to reality. I think the things that you're doing here in Ireland, we would like to learn from as well, because as Kate said, these challenges are facing all of us, and by sharing knowledge, hopefully we'll be able to all make a difference together. Thank you.
Thank you very much, Karen. Notwithstanding the savings and the example that you've given us, with already stretched health services, want to focus on sustainability strategies require at the very least front loading with resources. So how do we implement the necessary changes in sustainability?
Absolutely. I think, having that messaging from the leadership of health services, from the health department, from the CEOs in health services, to make it clear that this is a priority. It probably isn't a bigger priority. If we're wanting to carry on as a livable planet, we're wanting to make sure that we don't see these consequences coming back to the healthcare services. Having leaders clearly send that message that this is a critical priority and that it needs to have a focus, but at the same time demonstrating examples of where, rather than using more resources, we can use resources differently. We can save resources. In fact, there are many things that we do in healthcare, goods and services procurement, energy use, transport, that if we just did something different to what we're already doing without using more resources, we will actually make a significant difference. An example of this is in the area of unwarranted variation and low value care, which I think all of us acknowledge occurs in our healthcare systems. If we spend some time just focusing on how we could reduce those practices, we would save not only money, but the environment as well.
Excellent. Plenty for us to digest there. I would ask the audience at this point if you yourselves would reflect, and if you have anything that works well for you in your practice, perhaps you could share it with us in the chat box so that we can capture it. In QPS, we're a co-applicant and collaborator and lead knowledge user with a HRB funded project with an academic partner looking at how climate sustainability can be incorporated into medical education. And we will be using the prospectus and the competency navigator to spread those materials and share them when they come to fruition. So all that said, our next speaker is Ms. Rachel Kenna, Chief Nursing Officer, and Rachel is going to share her reflections on today and on the topics under discussion.
It's great. Thanks very much, Orla. And I'm also delighted to be here with esteemed international colleagues and national colleagues that I work with every single day. I suppose one of the things that strikes me when I'm listening to the talks this morning, and indeed colleagues here now, is the size of the challenge that we have in Ireland today going forward from this point. And there's a couple of interlinked challenges that I've kind of picked up that feel very real for me as kind of working within a system that's undergoing change. So we're running to, I suppose, have a patient and quality system that is ready for the changes that we are trying to complete. So we're not only moving to a new regional structure in Ireland in our health system with a new governance structure that's presiding over that. I would say we're also trying to, or we're going to have a more sustainable system, and we Karen, we understand why. And then Ellen Joan eloquent reminds us that our brains aren't really good at operating in a like that where there is so much going on. So it makes our jobs as quality and patient safety leaders seem ever more important in a time of this. When all those plates are moving around, that's the biggest, riskiest environment in an already kind of risky system. So when you think about what we have to do is we're at huge risk of losing some of our structure, some of our standardization, and increasing our variability in practice and trying to manage as we go through all of this. So to me, that means that we have a really big challenge in making sure that those kind of cornerstones or foundations of patient safety and quality care are maintained throughout the whole system. But they too are going to have to be flexible in how they're applied to allow staff to without allowing significant. The picture, Ellen, Joan, that you have with the Maltese, we don't get those animals in Ireland, but you can certainly kind of feel the risks that are associated with that. And I think there's a lot we can probably come out in the conversation, Orla, as we move through it, about how we build that culture of patient safety, because it has to come. We can have all the structures we want in the world. In a small country like Ireland, it's not going to make our system safer unless our people are bought into it and looked after within it, and that's both patients and staff. So we have the back to you.
Okay, there's a lot to spare. I'm reminded that that's a very unfortunate photograph when you mentioned appetite with somebody in an alligator report as well. Rachel, what do you see as the single biggest challenge in transitioning to the new system under Sloan to care for quality and patient safety? Just the one.
Yeah, no, I think there's many, but I think for me at the moment it's governance, and that it's really important that people working within the system know what they are responsible for, but also that the system, including the patients, know who's in charge. But I go to work every day, I know what I'm in charge of, but in a moving system, you might have to grab something else for a little while and bring it with you if you're in a leadership capacity, or if you're not in a leadership capacity at the top, underneath you're still leading and you might need to push something up a hill, and that's the way that we're going to have to work. So governance, I think, is going to be a really big challenge for us.
Thank you. I couldn't agree more. And with regards to culture and quality and patient safety culture, how do we maintain and build that patient safety culture in a changing system?
Yeah, I mean, I think that's a really important question. I've been challenging myself with that throughout the morning, and I think you've got the old chestnuts that we all rely on, with this training and learning. And I think we need to build our learning culture. We need to learn together better. We need to learn together more. We need to look at interprofessional education. And I think one of the most important things about turning a culture as a clinician, even though I'm not in frontline practice anymore, every time I go to a talk or a conference or I read something, if there's a patient story in it, I remember it and I relate to it. And as clinicians, the patient voice is really, really powerful in our learning together. And I think that helps to build the culture. The other thing that I'm really struck by, but that both Ellen, Joan and that Karen have mentioned, is that we can take some lessons from the sustainability approach, is understand the impact of what we're doing. And if clinicians understand the impact with better data and see whether we're doing a good or a bad job, they will work to make that better or to sustain good. So I think they're the two things about, for me, that are going to turn the culture or keep a good culture and make it grow.
Thank you. Thank you very much for that, Rachel. So we're doing very well on time at this QPS talk time for once, I think. So we're now going to move over to a general panel discussion and take some of your questions from those attending. I'm going to start with you, Ellen, Joan. I can just imagine that executives and inspectors get very, very nervous when they hear you talk about risk appetite, or when that conversation on risk appetite starts. So what's your advice to executives as to how they can support their frontline staff in intelligent risk taking, as you so eloquently put it?
Yes, it's not like indeed put your head in the crocodile's mouth. It's all about like lead by example. So when you lead by example, this morning I gave an example also because I'm in an accreditation business in a daily life. I'm the CEO of an accreditation body, and they asked me about the same question. And we said, well, we have one differentiator when we come into our care organizations. and we see how well are they doing with the topic of intelligent risk taking. It's about how they lead by example. It's about they empower their staff. So there's plenty of room to for the departments to have their own improvement initiatives. They have most frequently they have like these daily huddles where they discuss what happened and that they follow up what they did afterwards. And the executives, they also follow up. So they keep their staff accountable. And keeping their staff accountable and assure there is follow-up is a really important advice. Otherwise, either you have a culture where you tolerate things and risks and incidents will happen, or, and then incidents and risks will happen as well, you have like the mentality of the head on the plate. And we don't want that. So it's really lead by example. And I'm not sure if I do have time for a practical example. Or
Absolutely, please share.
There is an academic hospital, and for example, what they did also for the intelligent risk taking is also about stimulate being vulnerable, stimulate shared learning, and stimulate doing that in a transparent environment. So what they did was every meeting they have to discuss their the cases. For instance, they do it with their patients. The patients is at the table.
Wow,
Yeah,
that's quite a culture shift.
that's quite a culture shift. So it's also showing like what is the new normal. They are now accustomed to it. There is a patient on the table, sitting at the table.
Patient who's involved in the incident or a patient representative?
Both.
Both.
Yes.
That is quite a shift. We include patients and patient representatives on our working groups, our steering committees, and our incident management committees.
Yes.
A lot of the time, but actually including a patient at the front line in an M&M meeting would be novel for us.
Yeah. So they started with the representatives because it's more safe because you have the distance. But what you said, what you remember most is the patient story. So we work in healthcare and we do that with a patient with an intrinsic motivation to do the best and to deliver quality care. And if you can make this connection with the patients or relatives who suffered from the incident, then you have the floor for progress. If you have a culture for accountability, not for blame. So it's really, really a nice example of create a new normal.
Indeed. I really like the distinction you make between accountability, blame, and you know that term intolerance, accountability, blame, and tolerance.
Yeah, and it's a strong distinction. So you notice when you enter a care institution or a culture, what is it? Do they tolerate it?
Or would hold people to account?
Yeah.
Without blaming them.
Exactly.
Yes. Be able to hold people to account for the quality and safety of the service and they deliver, not tolerate deviation without blaming.
Yeah.
Excellent concepts for us to take away. Karen, are you quick and wind up?
Yeah. It's like watching tennis.
How can we engage busy clinicians? We're used to being the experts in their areas when sustainability isn't necessarily either an area they're comfortable with or expert in.
Yeah, absolutely. And I think, you know, what we've seen around the world is having an analytical mind, which most clinicians do and healthcare professionals, being interested in evidence base is important. So being able to demonstrate what that benefit will be, what the impact will be on patient care, because we know that clinicians are really focused on quality care for their patients. So making that connection between the two is critical in getting that engagement. And there's a lot of good evidence around to be able to have that sort of conversation. I think also creating a burning platform for change. I know, many people in the safety and quality area are interested in how do you support that change management. And so we have a burning platform now. As I was saying this morning, the platform's already on fire. So what we want to do is really support people to think about how do you continue to deliver good quality care, in fact, possibly even better quality care. How do you do it at a lower cost and make sure that it's good for the environment and for your health service? So those are the sorts of messages that need to be used to engage the clinical workforce. The role of leadership here is absolutely critical. I was fortunate enough a number of years ago to participate in a Harkness Fellowship. And I did some work as part of that, looking at high-performing healthcare services. And those services that had a combination of characteristics were the ones who really had a learning organisational culture. So if that's the sort of culture that you can foster within the organisation, people are happy to learn, they want to improve, and you get that messaging from the leadership, then I think you've got the right kind of recipe to be able to make change.
Thank you. Thank you for that, Karen. There are a couple of questions coming in for you in the chat box, but I'm going to give you a minute to think about the next question,
that's a good question
for you from the chat box. And while Karen's doing that, Rachel, heading back to our theme this morning, our musical theme, in the midst of sound care implementation and all of this change, and where people are grabbing on to whatever they need to, how do we ensure that we're playing off the same score or singing from the same hymn sheet?
Okay, I'll stick with the analogy. And in order to sing from the same hymn sheet, everybody needs the same sheet of music. So I go back to what we all do on a daily basis, but particularly reflecting the work that Kate and I do here in the department, is that we build part of that health, that safety and quality infrastructure that's so important to keeping everybody on the same page, in the same place, singing the same song. So you do need legislation, you do need regulation, you do need policies, procedures, guidelines, we need data, we need information, and we need to be able to analyse it. So you need all of these things, and that's what keeps us all on the same page and doing the same thing in the right way for patients. You cannot have that too structured that it doesn't allow innovation. So I think it is about a balance in terms of being able to keep everybody doing evidence-based, data-driven, allowing that flexibility for innovation so that people can have the boundaries and supports to do that safely. That's really important.
Thanks very much. Just a few little jobs for us all. So Karen, back over to you, and with the growth in AI in healthcare, how do we balance AI as an enabler for healthcare and quality improvement with the sustainability agenda? And you're speaking in a country of many data centres.
Yes, indeed. I better be careful. No, thank you for that great question that's come in. We've run just in the last year an executive innovation forum in Australia with the leaders from many of our healthcare services on exactly this topic, AI and healthcare. And we brought experts in from around the country, particularly in that nexus between AI and healthcare. And one of the key takeaways from that for me was AI is a tool, like any tool, but we've used many tools over the years, and so we still need to be thinking about the risks. about appropriate governance, about ethical implications. We need to make sure that the tools are properly assessed. And we need to understand those tools. I don't know how many healthcare professionals understand that AI tools can hallucinate. And unless you really understand the underpinnings, you may take some of the things that come out of AI for granted as gospel. And we know that that's not necessarily the case. So we've been thinking about what does governance, what does clinical governance look like in a world in which our healthcare professionals are using AI tools? And it's not that we don't want them to be used, we do, but they need to be used safely, just like any other tool. We're responsible for that. Has the organisation got the right data governance framework? Are all of those checks and balances actually in place? And what are we doing about training our staff to ensure that they can safely use AI? And when we're thinking about sustainability, I don't think these are mutually exclusive. We have the ability to use these tools to make us smarter, to help us speed up processes, to be able to scour the literature that we were talking about, the evidence base, and really bringing that synoptically to our healthcare professionals. So there's a lot of opportunities as well as the risk. With any tool, we need to balance those. I won't get into the hot topic of the amount of energy that these tools pull, because that has implications for sustainability as well. And I don't think that that's often well understood. But there's some real positives, but we do need to do this safely.
Thanks very much for that, Karen. Looking at the chat box, and I know this one is directed at you, and the question is what training staff had to undergo. Now, the questioner hasn't specified the training the staff had to undergo for which initiative, but I think in particular the M&Ms with patients on board. Was there any particular training program?
Yes. So I think even before the training started, that it was an initiative that was led by staff. So it was empowered by the executives, but it was led by staff. So they set the tone and the pace. So I think that was really important, that they really felt empowered. They were able to take up with that leadership. So in this particular example, it was not just that they were given the opportunity to do it themselves, to practice and create their own safe learning space. Because they had this safe learning space, it went quite rapid. So it was quite, I think it was within 1 year that they were sitting actually with patients and with relatives.
Okay.
Because they owned it.
Okay. But clearly the environment was such that there was a very strong patient safety culture, and even with that, there was a year of a run-in.
There was a quite a strong, but then again, sometimes you only need one person who's going to take the lead and take it off. And it was here as well. So there was one pioneer, there was one anesthesiologist, in fact, and he drove the change. So sometimes even that is enough, that you have one person who is persistent, who is brave, and yes, he or she needs to be empowered by the executives to avoid blame. But if you have this person, foster him, empower him, support him.
Okay. And did it take off?
Yes.
Did it spread? Did it spread to other institutions? Did it spread to other meetings or other programs of work?
Well, this was quite a large organization, so it spread within the organization. And this is where you see the hard part. That is difficult. This morning we had the evidence based on the knowledge that we know what's working, and despite that we know it, it's really difficult to get it very broadly implemented. We also have to come in. We have to And we do make sure that there are training programs available to grow professional leadership on the frontline level, on the frontline staff, that they can take off. So you can do like crew resource management trainings to learn to speak up and also to learn to listen, to understand. You can also have like training on just very simple communication skills, how to be vulnerable in your relationship to the clinician with your patient. So we can organize these things. We know them. It's not like how do you say it? Magic, rocket science. It's not rocket science. So I suggest we know what to do. We just have to do it.
Or is that easy?
Sometimes it is.
And we were saying it might be easy there, but it's not so easy. Kate, we heard from you. Could you share your takeaway messages from the seminar this morning and from our session just now?
Yes, so I've just jotted down a few here. I really like the question that you put out to the audience, and I think it's a good one for us to take forward about what legacy of patient safety we're leaving for the next generation, and that obviously resonates with the climate question of how we're going to leave the planet for our grandchildren and future generations. We've talked a lot about, I suppose, for all of this change to happen, it really depends on the people working in the system. Many of those people are probably still tired and recovering from COVID. We talked this morning about how certain industries and countries are trying to get back to the way things were. And I think we really have to stand our ground and push forward to say we're not going back. Like every big pandemic changes the world in fundamental ways, and we need to do that. I also think there's a little bit of fear, and it's probably our job as policymakers in creating that system. So while we have legislation and regulation, how do we take the fear of innovation, the fear of vulnerability away for frontline teams? Because people may think, well, what difference does it make our little effort here or that? In Ireland, I suppose, when we speak about that, a lot comes up about the culture of litigation and the culture, obviously, we have open disclosure policy and legislation now, and it's not that these things are forced on people, it's really about how do we set that standard and show to the public what the standard is. I think in the patient safety agenda, you'll see over the years in other countries are not very different. The big leaps we make come from very big and public and politically charged tragedies and events, and that drives change. I'm hoping we're coming out of that era now, but the thing that has always struck me, and we continue to see, and going back to Ellen Jones' example of the patient being at the table, in the policy table we now do see, and we have very in-depth and open conversations with people who have suffered quite recent harm and quite recent loss. And a big part of what they want is how can they contribute so the same thing doesn't happen to other people. So I would be confident that we will be able to bring that further, because I think there's an appetite. Some of the fear at the front line is probably we've had a big patient empowerment movement in Ireland. We've encouraged people to speak up and to be part of things. And I guess the healthcare professionals have to adapt to what does that mean for me. We now probably have some learning to do with the public and the patients about that healthcare and medicine is not perfect, and that there's, I suppose, limits to what it can achieve, so that then they are co-creating, interacting, questioning, but in a more informed and collaborative way. Obviously, you've talked about AI, and in Ireland, the app was launched, our first toes in the water into the digital space. I think we'll go quite quickly in Ireland. But to remember that the next generation of healthcare professionals, I think some of that fear of AI could be a bit of a generational thing, because the next generation come up are digital AI, that they already know how to use this and understand it. So I think once they come into the workforce and into leadership positions, it'll be a whole different thing. I think the other thing that struck me this morning and in the conversation here, a lot of the elements of what is needed are really the key elements of what we still call and used to call leadership. Going back to like the patient safety 2 kind of agenda, what does good look like, and sharing that, and the fundamental importance of communication and communication skills. We were reminded this morning, so I'm going to say it here so people out there can hear it, that healthcare is probably the industry with the most smart people in it. So in a country, your healthcare system is probably where a lot of your smartest people are. So we shouldn't kind of forget that we have a big capacity and capability to do that. And I think the challenge for us, so there's the piece about encouraging people to speak up, which we've done, but the daring to listen. And I think for us, particularly in the Department of Health, that's often a challenge that people want us to listen to what they're saying. So whether they're patients or frontline workers, that's a big piece. And finally, I think in terms of the climate change, because that affects us all personally as well as professionally, and a key kind of way for people to see how they could make that difference might even be to map across the things we are doing anyway for quality and how they contribute to that sustainable change. So I think to wrap up for us is very, I suppose, thought-provoking this morning, and good to see other countries grappling with the same ideas and the same challenges, and for us then to see what's the best way of taking learnings from there and integrate it into the patient safety culture and what we're doing here to support patients, to support better health outcomes, continuing to have longer, healthier lives, and particularly the workforce, so they feel supported to continue to work in such a demanding and complex service. So I think anytime we have this kind of event, it also, I suppose, renews people's kind of hope and motivation that we are making things better. So if you look every year, even or 5 years back, the changes that we've made, and there's no challenge too big for us, even if it is the burning of the planet. We have to, particularly for the generation coming behind us, to say we can do this as we have done other things, and maybe it's just the way that we need to do it needs to look differently than how we did things in the past. So.
Well, folks, I'm sure you'll agree that Kate was some student in her day in honours answer to an honours question. And 4 hours of workshop condensed into 5 minutes of commentary. Thank you so much, Kate. I'd like to follow now, but does anybody have a parting message that you'd like to share with the audience?
Okay, a closing comment. My key message would be explore your boundaries and practice your risk behavior.
Thank you. Karen?
Climate change, it's the biggest health threat facing us. We know that healthcare services are significant contributors to carbon emissions. And really what we want is everybody focused on this in healthcare services, and it will be important for patient safety and for the globe.
Thank you, Karen. Rachel?
I think for me, just in the spirit of today, that safety is a global problem. And I think global problems mean global solutions. And I don't think that we in Ireland or any country can underestimate the benefit of global partnerships. So I think today has been a testament to that.
Indeed. Thank you. Thank you all so much. And thank you all for joining us on the webinar. As ever, if you're interested in hearing more on quality and patient safety, we have our next session, our human factors in healthcare. If you're interested in hearing more about the impact of civility in the workplace and how we can support psychological safety, you can listen back to previous QPS talk times that have addressed these important communication matters. A gentle reminder of our resources and upcoming events. Registration is now open for our next QPS talk time. I'd also like to, in Human Factors, episode 34, episode 37, we'll look at simulation to improve quality and patient safety, and that will be followed by a teaching session on how to design a survey for QPS. And then in line with our Clinical Audit Awareness Week, we're having a special QPS talk time on clinical audit. You can watch back on those previous episodes using the link. They're also available on YouTube and, as I said, on Spotify. You can follow us on other social media platforms, LinkedIn being the main one, and we'd invite you once again to join our mailing list. Thank you once again for joining us today, and a huge thank you to my colleagues here, to Juanita on the keyboard, keeping us all on the straight and narrow, to Rachel, to Ellen, Joan, to Karen, and to Kate. Thank you all very much, and talk to you next time.
Thanks to you too, Orla. Okay, thanks everybody.